Welcome to the 2018 Utah Medicaid Statewide Provider Training. My name is Rachel Beecher, and I am the Bureau of Medicaid Operations Trainer. I'm going to start today's training with some important information about the provider enrollment process. As of July 1st, 2016, all new applications are submitted online through the PRISM system. You will need to have the NPI, SSN, FEIN, date of birth, licenses, and ownership information ready for each new application. An application can be started at our website, medicaid.utah.gov. You will first click on the tab titled Healthcare Providers, and then you will click on the first link titled Become a Medicaid Provider. A Utah ID will be required to start a new application, and to obtain one, you will visit login.utah.gov. You will then choose the enrollment type that is appropriate for the provider. A page will appear asking for the name of the provider, tax ID, provider requested effective date, and all fields marked with an asterisk need to be completed. You will always maximize the windows that pop up. Once all of the information is entered, you will press the Validate NPI button. And for enrollment types such as individual, group, facility, agency, organization, and Indian Health Services, in the lower right corner of the screen, an error may appear, but as long as the NPI and tax ID are correct, you will press the Finish button and move on with the application. You will complete all required steps. The billing provider step is optional. If your provider practices as part of a group, you will need to add the group NPI to the billing provider step. Every new application will need a provider agreement and provider user access agreement, and these forms can be obtained at our website, medicaid.utah.gov/Utah Medicaid Forms. If the application is not submitted within 60 days of the day it was started, it will be removed from the system, and at this point, the process would start over again. All providers are required to re-credential every 3 to 5 years, depending on their risk level with CMS. Utah follows CMS guidelines for re-credentialing, and re-credentialing is done through the PRISM system. A letter will be mailed to the Pay-To address on file when the provider is due to re-credential. Providers enrolling in Utah Medicaid will receive the date their application is correctly and completely submitted as their effective date. A backdate can be requested for extenuating circumstances, but an email will need to be submitted to our provider enrollment team at providerenroll@utah.gov. The email must include the requested begin date, provider's NPI, and a detailed justification of why the request is needed. All providers enrolled with Medicaid prior to July 1st, 2016 will be required to validate information converted from the legacy MMIS system. Online training for validations can be found here at our website, medicaid.utah.gov/PE training. You will then select Validating Converted Medicaid Provider Information in PRISM web-based training. Frequent questions when PRISM troubleshooting. I need to update my EDI and provider information. How do I log into PRISM? And the answer? A validation letter is required to log into PRISM for the first time for providers enrolled prior to PRISM Go Live. You can request a validation letter by emailing providerenroll@utah.gov or by calling our Medicaid hotline at 1-800-662-9651 and pressing options 3 and then option 4. In order to complete the validation process, all steps that are marked as required and optional inside the Business Process Wizard need to be clicked on and updated. And another frequent question. I am trying to validate, but I am stuck on step 2 locations. How can I get this step to complete? And the answer? Click on the Step 2 Locations link. You will then click on the 00 link that says In Review. If there isn't one in review, simply click on the one that is available. After clicking on the 00 link, you will be on the Location Details page. Scroll down to the bottom of the page. There will be a heading labeled Address List, and directly above the address list is a button that says Add Address. And remember to always maximize new windows that pop up. Once clicking on the Add Address button, a new window will open, asking for an OIG correspondence. If this address is the same as the mailing address, you will then click Copy from Mailing Address Radio button. If you need to manually input the address, you will just click on the Add Address button at the end of the zip code. Now that the address is entered and validated, press the Next button. It will now ask you for a financial correspondence address. You will fill this out and select how you would like overpayments recouped at the bottom. Then press OK. You will now be able to move on to Step 3. And another frequent question. I can't get the View Upload Attachments to complete. What am I missing? All new validations require a provider agreement and provider user access agreement. You can find a list of the required uploads inside of the step. You first click on the View Upload Attachment step, and then under the instructions for Upload Attachment, there is a link to the provider user access agreement 4 lines down. At the top of the page, there is a Required Credential button. You will click the button to see what is required. The licenses required for upload will be under 01 license. Click on 01 license, select 04 document type, and then press Go. From this page, you will be able to print the provider agreement and review what other documents need to be uploaded. Close out the window and click on the Upload Attachments button to upload all of the required licenses and documents. In order to complete the validation or the new enrollment, complete the final step, which is Submit Modification Review, or Submit Enrollment Application for Review. Now that I have completed the training section on provider enrollment, Jeanette Little and I will be moving on to Medicaid 101, where we will discuss general Medicaid information that includes how to bill, dental plans, Medicaid members, member responsibility, coordination of benefits, and our lookup tools. Medicaid uses 2 different payment models to reimburse for services delivered to Medicaid-eligible members: managed care and fee-for-service. Medicaid-eligible members may have fee-for-service or a managed care plan, depending on the county they live in. A managed care organization includes accountable care organizations and prepaid mental health plans. Providers are responsible for verifying Medicaid eligibility and determining if a member is enrolled with an MCO before services. Medicaid eligibility can be verified using our Access Now Eligibility Lookup Tool, or ANSI 270-271. A provider who accepts Medicaid agrees to accept the MCO payment as payment in full. This includes any deductible, coinsurance, or copayment owed by the Medicaid member. A member may not be billed for services unless specific requirements are met. If a Medicaid member received a physical health service and has an ACO, send the claim to the ACO. An ACO contracts with Medicaid to pay for physical health services provided to Medicaid members. Right now, 85% of Medicaid members receive their physical health benefit from an ACO. Utah Medicaid's ACOs are Health Choice Utah, Healthy U, Molina, and Select Health. Enrollment in an ACO is mandatory in the following counties. Enrollment in an ACO for members in other counties is voluntary. The health plan is required to cover the same services that the fee-for-service network covers. The ACOs may have their own prior authorization or other utilization review requirements. If the MCO denies your claim, you can file an appeal with the MCO. The appeal needs to be filed within the timeframe specified by the MCO, and failure to file your appeal within the required timeframe may prevent you from obtaining payment. We will provide additional training on appeals in the future. Emergency Services Program for Non-Citizens has been updated, and specific policy for this program can now be found in Administrative Rule R414518, Emergency Service Program for Non-Citizens. And this defines the scope of service that is available to individuals who meet coverage criteria under the Emergency Service Program for Non-Citizens for the treatment of emergency medical conditions. Utah Medicaid contracts with Delta Dental and Premier Access for pregnant women and children living in Davis, Salt Lake, Utah, and Weber counties. And if you serve a Medicaid member that is enrolled in one of these plans, then you would send the claim to the dental plan. Dental plans must cover the same services that the fee-for-service network covers. Adults ages 21 and older who qualify for Medicaid because of a disability or blindness are eligible for dental benefits under fee-for-service and not through a dental plan. These same members receive the same dental benefits as pregnant women. The claims for these services will be sent to Utah Medicaid and not to a dental plan. These services for members who are visually impaired or those with disabilities residing in Salt Lake County shall be provided services through the University of Utah School of Dentistry. For Medicaid members who are visually impaired or those with disabilities who reside within a nursing home and are 21 or older, covered dental services are not allowed to reduce the nursing home liability. Covered dental services must be rendered by a Medicaid provider and billed directly to Medicaid. Program coverage and limitations have been updated and are available in the Dental Oral Maxillofacial and Orthodontist Services Provider Manual and the Utah Medicaid Coverage and Reimbursement Code Lookup Tool. Under the PMHP, Medicaid contracts with local county mental health and substance abuse authorities to provide mental health and substance abuse services to Medicaid-eligible members. Prior to delivering services, providers must verify the member's PMHP through Access Now, Eligibility Lookup Tool, or ANSI 270-271. If a member received a mental health service or substance abuse disorder service, send the claim to the PMHP. All Medicaid members enrolled in the PMHP may also receive services from a federally qualified health center. PMHP authorization is not required. American Indian and Alaska Native Medicaid members may receive services from Indian healthcare providers that include Indian Health Program or an urban Indian organization. Medicaid members with subsidy adoption may disenroll from the PMHP on a case-by-case basis for outpatient mental health and substance use disorder services. A Medicaid member is required to present their eligibility card before each service. Every provider must verify each member's eligibility every visit before rendering services, and presentation of the Medicaid member card does not guarantee a member is eligible for Medicaid. You would verify the member's eligibility, determine whether the member is enrolled in a managed care organization, emergency-only program, or the restriction program, assigned to a primary care provider, covered by a third party, or responsible for a copay or co-insurance. And eligibility and health plan enrollment may change from month to month. Retain documentation of the verified eligibility for billing purposes, and you can always verify their eligibility through our Access Now Eligibility Lookup Tool or ANSI 270-271. Here is an example of our Eligibility Lookup Tool, which you can find at medicaid.utah.gov/eligibility lookup tool. To submit an eligibility inquiry on a specific member, you will enter the provider ID date of service, and a combination of the following criteria: 1 value from the unique identifiers column and 2 values from the demographics column, or all 3 values from the demographics column, and only exact matches will return results. Remember to print and file a copy of the eligibility on the date of service as proof if needed. And providers should also note that the eligibility lookup tool is currently showing fee-for-service network by the red arrow, and when a member is not enrolled in a managed care plan, that's what it will list. Fee-for-service claims should be billed to state Medicaid. Medicaid members may be billed for copayments and coinsurance. Medicaid members may only be billed for broken appointments if there is a policy in place for broken appointments for all patients, not just Medicaid members, and the member has also signed an agreement to pay for broken appointments. Traditional and non-traditional Medicaid members may be billed for non-covered services when all 4 of the conditions below are met. The provider has an established policy for billing all patients for services that are not covered by a third party. The member is advised prior to receiving a non-covered service. The member agrees to be personally responsible for the payment, and that agreement is in writing between the provider and the member, which details the service and the amount to be paid by the member. PCN members may also be responsible for non-covered services. You can see that in the PCN manual for covered and non-covered services. For complete information regarding our Medicaid members' billing, please see Section 1, 3-4, and 3-5. Located on our website under Forms, we have a sample of a financial agreement form that covers all 4 areas that were shown in the prior slide in order to bill the Medicaid member. When billing for emergency services provided to a non-citizen, any payment made by Medicaid for a service is considered payment in full. Once the payment is made to the provider for covered services, no additional reimbursement can be requested from the member. Because the Emergency Medicaid Program for non-citizens has a very restricted scope of service, it does not have the same restrictions on billing the member. If a provider does not receive payment from Medicaid because the provider failed to follow procedure to get a service covered, the provider is prohibited from pursuing payment from the member. If payment is not made because the service was not an emergency or the service is not covered under the program, then the member can be billed for those services. If a service is a covered service and meets the Medicaid definition of emergency, Medicaid will pay for the service. However, if a non-citizen eligible for emergency services only presents at the ER with symptoms that do not appear to be emergent in nature, the provider would be prudent to inform the member prior to the service that that service might not be covered by Medicaid. In that case, the member will be financially responsible for paying the bill. Medicaid members are responsible for certain charges that include charges incurred during a time of ineligibility, charges for non-covered services, including services received in excess Medicaid benefit limitations, charges for service which the member has chosen to receive and agreed in writing to pay as a private pay member, spend-down liability, and cost-sharing amounts, such as premiums, deductibles, coinsurance, or copayments imposed by the Medicaid program. Some Medicaid members share the costs for certain services that include prescription drugs, inpatient hospital services, non-emergent use of the emergency department services, and cost-sharing in the Medicaid program that include coinsurance, copayment, deductibles, and premiums. Some services are exempt from copayment. Even if a member ordinarily has a copay, do not collect a copayment for the following services: family planning, preventative services that include vaccinations and health education, or pregnancy-related, emergency services, non-emergent use of an emergency room requires a copay, and provider preventable condition services. Federal regulations exclude certain services from cost sharing, and those include individuals through the age of 18 years, any individual whose medical assistance for services are furnished in an institution, American Indian and Alaska Native individuals, individuals whose total gross income before exclusions and deductions is below the temporary assistance to needy families standard payment allowance. These individuals must indicate their income status to their eligibility caseworker on a monthly basis to maintain their exemption from the copayment requirement. Qualified Medicare beneficiaries and individuals who are receiving Medicaid due to having breast or cervical cancer. Other than the cost-sharing responsibilities discussed previously, members are not responsible for a claim or portion of a claim that is denied for lack of medical necessity, charges in excess of Medicaid maximum allowable rate, a claim or portion of a claim denied due to provider error, a service for which a provider did not seek prior authorization or did not follow up on a request for additional documentation, a claim or portion of a claim denied due to changes made in state or federal mandates after services were performed, the difference between the Medicaid cost-sharing responsibility and the Medicare or Medicare Advantage copay. Medicaid pays the difference between the Medicaid maximum allowable fee and the total of all payments that were previously received by the provider from a third-party liability. Members aren't responsible for deductibles, copays, or coinsurance amounts if the payments were added to the amounts paid by third parties, equal or exceed the Medicaid maximum for that service, even if the Medicaid amount is zero. The member is also not responsible for private insurance, cost share amounts if the provider accepted them as a Medicaid member. Medicaid pays the difference between the amount paid by private insurance and the Medicaid max allowed amount. Medicaid won't make any payment if the third party pays equal or greater than the Medicaid allowable rate. Federally qualified health centers and rural health clinics have two options for payment. They can either bill 100% billed charges and then all edits would apply, or they can bill by the encounter. They would need to bill the T1015, they must bill all CPT codes that apply, at least one CPT code must be an approved encounter code, and if only the T1015 or only the CPT codes are billed, then the claim would be denied.
Now let's go over the coverage and reimbursement lookup tool. Most information on policy and benefits can be found in the provider manual at medicaid.utah.gov/. The first thing you're going to select on this page is healthcare providers. Then you will select coverage and reimbursement. On the coverage and reimbursement lookup tool, you can find information like your coverage status, the charge factor, which is your reimbursement rate, doesn't need prior authorization, allowed age range, copayment information, and global period information. On this screen is where you would select your provider type. So I selected provider type 20, which is a physician, and I entered code 77080, put in a date of service, and then click on search. After you click on search, this is the page that will come up. I want you to notice the type of service is the technical part, and as you scroll down, you will be able to see the professional part as well. Here on these pages will give you the information you're looking for. Is it billable by you as a provider? Is it covered under the benefit plan you're looking, and how much you will be paid, and does it require a prior authorization? Now, if you want to search for a Medicaid manual, you'll go back to our home page. You will select healthcare providers, and then you will select provider resource and information. The next page that comes up will be where you can select manuals, Medicaid information bulletins, forms, and other contact information for providers. So I'm going to select Utah Medicaid Provider Manual, and then I will select Medicaid Provider Manuals or Medicaid Information Bulletin. After I selected manuals, this is the page that will come up, and you will locate the manual for your specialty. As a note, Section 1 applies to all providers, and all providers are encouraged to read Section 1. Just as a note, the date at the top of the page is the date applied to the manual, not the page. Also, the table of contents is hyperlinked.
Before submitting a claim to Medicaid, a provider must submit and secure payment from all other liable parties, such as Medicare Part A and B. And you can always get more information on the Medicaid General Information section regarding this. Claims denied from Medicare as non-covered services should be submitted to Medicaid Fee-for-Service and not to the crossover mailbox. If the primary payer made line-level payments on the claim, please report line-level data in addition to the claim-level data to Medicaid. Medicaid is the payer of last resort. Reimbursement for crossover claims and other TPL will be limited to the Medicaid fee schedule for all types of service, which include FQHC and Indian Health Services. The electronic mailbox for Medicaid Fee-for-Service ends in 001, and Utah Medicaid crossovers ends in 005. Corresponding EOB for zero pay from Medicare will be faxed to 801-323-1584, and for any other corresponding EOB for zero pay, please fax to ORS at 801-536-8513. Providers need to submit their own corrections to claims less than 3 years old by submitting either a replacement or void claim. The data elements needed to identify a replacement or void claim include claim frequency code, 7 for replacement or 8 for void, electronic X12 element 2300 CLM05-3, paper UB04 form locator 4 position, CMS 1500 box 22, transaction control number of original claim to be replaced or voided, electronic X12 element 2300 REF02, paper UB04 form locator 37AC, and CMS 1500 box 22 original transaction control number. For issues regarding overpayments and credit balance on claims over 3 years old for fee-for-service, there is an electronic payment adjustment request form. If a payment adjustment is required on a claim that is less than 3 years old, a replacement claim must be submitted, and the form is located on our website. The form may be filled out online before printing. One form is required per claim. All required fields must be appropriately filled out, or it will be returned to the provider. Checks for Medicaid operations related to credit balance, TPL for crossover claim payments, and overpayments older than 3 years, mail them to Bureau of Medicaid Operations Payment Adjustments and the following address, and checks for third-party liability payments, excluding crossover claim adjustments, to Office of Recovery Services Team 85 and the following address. In order to be eligible for interpretive services, a member must be eligible for Medicaid. You can verify their eligibility by using our eligibility lookup tool. If they are not eligible, they are not eligible for interpretive services. If a member is enrolled with a managed care plan, you will need to call them directly. When a member is enrolled as fee-for-service, determine CPT coverage by referring to our coverage and reimbursement lookup tool located on our website. And when both the member and the service qualify, then you can call one of the contractors listed in the General Attachments section, Interpretive Guide on our website. Give the required information below, which includes member's first and last name spelled exactly as on the Medicaid member card, the member's date of birth, 6 digits only, member's Medicaid ID number, your NPI number, and the language requested. Timely filing for fee-for-service. All claims and adjustments for services must be received by Medicaid within 12 months from the date of service, and new claims received past the 1-year filing deadline will be denied. Any corrections to a claim must also be received or adjusted within the same 12-month time frame. If a correction is received after the deadline, then no additional funds will be reimbursed. In the case of Medicare crossovers, all claims and adjustments must be received within 6 months of the Medicare decision. The 1-year timely filing period is determined from the date of service or from date on the claim. The exception to this is for institutional claims that include a date of service span. The through date of service on the claim is used for determining the timely filing for institutional claims. And for any additional information, please see 42 CFR 447-45. In regards to record keeping, Medicaid providers must comply with all disclosure requirements in 42 CFR 455 Subpart B, such as those concerning practice ownership and control, business transactions, and persons convicted of fraud or other crimes. Every provider must comply with the rules regarding records noted in Section 1, General Information, Chapter 4. The Provider Manual is found on our website at medicaid.utah.gov. You will click on the link Medicaid A to Z. You will then click on the S, and after that you will click on the link for Section 1, General Information for Providers.
Hi, my name's Jeanette Little, and I'm a claims manager here at Medicaid. Today I'm going to be going over what's new with Medicaid.
Medicaid is making changes to the provider manuals. We are moving policy from the provider manuals to the appropriate Utah administrative rule within R414, Healthcare Financing, Coverage, and Reimbursement Policy. These changes began July 1, 2017, and will continue until all manuals are updated. Moving Medicaid policy to the administrative rule allows you as a provider the opportunity to review and comment on the rule updates. We encourage you to become familiar with the administrative rule because Medicaid coverage policy will be relocated to the appropriate rule based on the service coverage.
The manuals are also being streamlined. For example, your laboratory services and women's services are now located in the Utah Medicaid Physician Service Manual. As part of the manual revision, information regarding specific codes will be moved from the Provider Manual to the Utah Medicaid Coverage and Reimbursement Lookup Tool. The provider manuals will continue to be a reference for criteria and reporting instructions. Providers are encouraged to become familiar with the updated rules and manuals, noting changes in the structure, format, and content of the manuals. Providers are required to follow the coverage policy criteria and prior authorization. Utah Medicaid submitted a state plan amendment to the Center for Medicare and Medicaid Services to update cost-sharing amounts with an effective date of October 1st, 2017. The new Medicaid cost-sharing is as follows: $8 for each non-emergency use of the emergency department, $75 for each inpatient hospital stay, that is an episode of care, $4 for each outpatient services, This includes your physicians, your podiatrists, your physical therapy, etc. $4 for each outpatient hospital service, with a maximum of 1 per person per hospital per date of service. $4 for each prescription, $1 for each chiropractic visit, which is 1 per date of service, and $3 for each pair of eyeglasses.
Eyeglasses are allowed for pregnant women and individuals under EPSIT check once every 12 months. Prior authorization is required to replace frames sooner than the 12-month period. Replacement lenses do not require prior authorization. So if the lenses just need to be replaced, the provider must use the existing frames. Prior authorization may be issued for a new pair of eyeglasses even though the 12 months have not passed since the member's last pair was dispensed, when one or more of the following reasons for medical necessity are met. There's a change in the diopter of 0.5 or greater in either sphere or cylinder power in either eye. A comprehensive or immediate vision exam shows that the change in eyeglasses is medically necessary. A change in the recipient's head size warrants a new pair of eyeglasses. The recipient has had some allergic reaction to the previous pair of eyeglasses. Or if the original pair is lost or broken or damaged beyond repair. The dispensing provider must obtain a written statement explaining this from the recipient or the recipient's caretaker to send with the prior authorization documentation. Starting November 1st, 2017, a prior authorization must be in place for any inpatient or outpatient hospital service where a PA is required for the procedure code. Hospitals should always verify that the physician received a prior authorization before they perform the procedure in order to be reimbursed. If a hospital bills a service that requires prior authorization and one was not approved, the hospital claim will be denied. If a facility or a hospital submits a claim for a service requiring a PA and one was not approved, the procedure requiring a PA will be denied, like an MRI. To review procedures that require a PA, please refer to our coverage and reimbursement lookup tool on our website. To verify or request a PA, please contact Medicaid. In the Salt Lake area, call 801-538-6155 or toll-free 1-800-662-9651. You can find additional information related to requesting a PA in our Utah provider manuals and in the Medicaid information bulletin on our website. As an entity covered under the Health Insurance Portability and Accountability Act of 1996, which is known as HIPAA, Medicaid must comply with HIPAA standards and their implementation guides regarding place of service. So to be in full compliance with the national standards, Medicaid has added an additional module to the existing prepayment editing tool. The place of service module will detect when services are billed in an inappropriate setting, and this will result in a denial on your claim. The new module took effect as of October 2017. Starting November 1st, 2017, Medicaid expanded to cover targeted adults ages 19 through 64 with no dependent children. The 3 groups that have been added are chronically homeless individuals, justice-involved individuals, and individuals needing substance abuse or mental health treatment. This group is also eligible to receive traditional Medicaid benefits, but they will not be eligible for dental benefits other than the limited emergency dental services.
In Section 1, in General Information, we discussed the policy of Medicare crossover claims. When a Medicaid member also has Medicare, a provider may either accept the member as having dual coverage or not accept either type of coverage. Federal Medicaid regulations do not permit a provider to reject Medicaid and accept only Medicare. For example, when a member has Medicare, a provider cannot bill the member for services that would have been provided under Medicaid and accept only Medicare payment.
So for an example of a pharmacy Medicare crossover claim, a dual eligible recipient presents to the pharmacy with a prescription for a Part B medication. The pharmacy processes the claim to Medicare and receives back a payment or a copay or coinsurance of $75. The pharmacy tries to bill the copayment coinsurance to Medicaid through the point of sale and receives a rejection. The pharmacy should dispense the medication to the member and submit the claim through coordination of benefits to the appropriate Medicaid trading partner number. Remember, there is no copayment, coinsurance to the dual eligible Medicare-Medicaid crossover claims. Coordination of benefit instructions for electronic claims are found on our website.
2018 Legislative Session Update. The following bills were passed during the 2018 legislative session. House Bill 12, Family Planning Services Amendments. This bill requires the Medicaid program to reimburse providers separately for the insertion of a long-acting reversible contraception immediately after childbirth, and it institutes a program of family planning services to certain low-income individuals, which requires a Medicaid waiver. House Bill 42, Medicaid Waiver for Mental Health Crisis Services. This bill requires the Department of Health to seek a Medicaid waiver for certain mental health crisis resources. House Bill 100, Medically Complex Children with Disability Waiver Program. This bill requires ongoing funding for the Medically Complex Children Waivered Program. House Bill 139, Telepsychiatric Consultation Access Amendments. This bill requires the state Medicaid program to reimburse for telepsychiatric consultations. House Bill 435, Medicaid Dental Benefits. This bill provides dental benefits to certain adults in the Medicaid program. It also requires a Medicaid waiver. House Bill 472, Medicaid Expansion Revision. This bill requires the Department of Health to submit a waiver request to provide Medicaid benefits to eligible individuals who are below the 100% federal poverty level. Since several of these bills require federal approval prior to the implementation, therefore, please read the upcoming MIBs, as relevant information for the related programs will be included upon federal approval. If you would like additional information on the waiver process, you can visit our website at medicaid.utah.gov/1115 waiver on our website.
Welcome to the prior authorization portion of the 2018 Utah Medicaid Provider Training. My name is Amber Lucero, and I am one of the prior authorization trainers here at Medicaid. I'm going to take a few minutes today to talk with you about how to know if you need a prior authorization, how to find and complete the correct forms, and how to know what to send in with a prior authorization request when you submit it. Once you click on the prior authorization link, the page will display where you will be able to locate all of the forms that are needed to submit a prior authorization. The first link at the top is where you will find the pharmacy PA requests, and for those of you that are looking for forms related to skilled nursing facilities, you will choose the link for resident assessment forms, but the majority of providers will find the forms that they need under the link that says General PA Forms. Once you click on the prior authorization link, the page will display where you will be able to locate all of the forms that are needed to submit a prior authorization. The first link at the top is where you will find the pharmacy PA requests, and for those of you that are looking for forms related to skilled nursing facilities, you will choose the link for resident assessment forms, but the majority of providers will find the forms that they need under the link that says General PA Forms. Once you click on the link for General PA Forms, another screen will open. Here you will find all of the general forms that are used for prior authorizations. The form at the top of the page, titled Prior Authorization Request Form, is the form that should be used if you do not see a form that is more specific to the services that you will be providing. For example, if you are requesting authorization for an enteral formula product, then you should choose the form that is specific for enteral formula. But if you are requesting authorization for a surgical or imaging service, then you would use the General PA form. Request Form Basics. Here are some important tips to remember about the request forms. Always use the correct form for the service you are requesting. There are unique fields that are necessary for certain services, and if the wrong form is completed, you will likely be missing some essential information that we need in order to process your request. Remember to always use updated request forms. Request forms are periodically updated, so be certain to check the Medicaid website monthly and use the most current version of the form. Fill in all of the required fields on the form. Most of the forms have an instruction page that will inform you of the fields that are required. Be sure to use the spaces provided. Make sure to always fax the request to the appropriate number. The fax number will either be directly on the form or on the instruction page that goes with each specific form. It is important to remember the minimum necessary rule in regards to PHI and to send the least amount of information to the correct people in order to accomplish the intended purpose of the use, disclosure, or request. At the request of providers, all of the request forms are typable. And last but not least, it is important to remember that these are the forms to be used for fee-for-service members and for services that are considered carve-outs. If the member has a health plan, the provider should contact the health plan directly regarding prior authorization requirements. Please see the completed examples of different prior authorization request forms in the attachment download section of this training. Prior authorization helpful tips. Be sure to check the member's eligibility before sending in any prior authorization requests. Equally important is to verify through the Coverage and Reimbursement Lookup tool that the code you are requesting requires authorization. Submit clinical documentation that is current and relevant. Please include all required documents, forms, and consents. Be sure to include all required modifiers such as the LL or RR modifiers used for DME items, or the RT and LT modifiers to indicate the right or left side of the body, or the GO or GP modifiers that are required for physical therapy and occupational therapy. If you are unsure if a modifier is required, please review the manual or contact the prior authorization staff for questions. Also, include conservative treatment documentation for services that require that type of information. This slide is just a quick recap of where you can find the Eligibility Lookup Tool and Coverage and Reimbursement Lookup Tool link under the Healthcare Provider section of the website. For those of you that did not participate in the earlier portion of today's training, please be advised that the Eligibility Lookup Tool provides detailed member eligibility information, including whether the member is enrolled in a health plan. A login is required to use this tool. If you have problems setting up a login or using the tool after you have set up your login, the number to contact is located in the bottom of the gray area on the screen. One thing to be aware of when using this tool is to make sure not to enter any spaces or characters at the end of each area of text that you enter. For example, after you type the member's first name, do not put a space. The system will not find a match unless it is exact. It is also important to mention that you can verify the next month's eligibility up to 6 days prior to the end of the month. This slide is a recap of information presented earlier in the training as well. Be sure to always verify that the code requires prior authorization using the Coverage and Reimbursement Lookup tool before you submit a request. Start by selecting the provider type that will be billing for the service. Enter the 5-digit code you are requesting. Enter the date of service. Keep in mind that you can't enter a future date. You should use the current date for services that have not been provided yet, but remember that it is the responsibility of the provider to also verify on the date of service that coverage has not changed. You are able to inquire on coverage for the previous 2 years for requests that are being authorized retroactively. Services that are not covered by Medicaid will give a system response that says, "Not billable by provider type." To enter all information and click the search button, a page will display that gives you coverage information. Be sure to review all information, including whether or not a prior authorization is required. And don't forget to read the special note if one appears in the yellow section at the top of the grid. Always be sure to scroll all the way to the bottom of the page and pay particular attention to the type of service area above the grid. There are many times when the coverage may be different depending on the type of service, so be aware of whether you are looking at the coverage pertaining to a rental or a purchase with DME items, and also the differences in the technical and professional and global components of certain services. Retroactive authorization. There are a limited number of circumstances when a prior authorization would be given after a service is rendered. The first of these reasons is when a member is issued Medicaid program eligibility retroactively. Retroactive authorizations must be requested within 90 days of the eligibility determination. Services provided in a medical emergency or medical supplies provided in a medical emergency are also a reason that we would issue a retroactive prior authorization. These services must be requested within 90 days of the medical emergency. We can also issue retroactive requests for surgical exceptions. For example, if a surgical procedure is changed or the need for an additional procedure is discovered intraoperatively, then a retroactive authorization can be submitted. These requests must be submitted within 90 days of the surgical procedure, along with the information verifying that the procedure changed from what was originally planned and why. There is also an allowance for anesthesia providers. If a surgeon fails to obtain prior authorization and the anesthesia provider cannot get their claim paid, the anesthesia provider can submit a request for prior authorization of the anesthesia codes. This request must be submitted within 90 days of the surgery and must include all required state and federal consent forms. Please be sure to review the Section 1 Medicaid Manual for complete details on retroactive authorizations and what information is required. Where can I find criteria? Well, there are a couple of places that you can find criteria. You can click on the link for medical criteria on the prior authorization page of the website. This link is found right above the link for the general PA forms that we discussed earlier. You can also find important information regarding criteria in program-specific Medicaid manuals by clicking on the Manuals link and choosing the manual that is specific to the type of services that you provide. Also, as we discussed earlier in the training, there is oftentimes code-specific information found in the notes on the Coverage and Reimbursement Lookup tool. If a service requires prior authorization and you are not able to find criteria in any of these places mentioned, you can call the Prior Authorization Unit, or you can send an email to medicaidcriteria@utah.gov. Please allow for a 24-hour response time and remember not to send any PHI with criteria requests. Just let us know the code or codes that you are requesting, and we will email you back information regarding what is needed for a prior authorization. Now, before we wrap up the prior authorization portion of this training, let's quickly go over what's new in prior authorizations this year. There are a few new and updated prior authorization request forms. Recently, we have updated the General PA form and the ABA form. In addition to those forms being updated, there are new forms for enteral formula, genetic testing, and substance use disorder treatment. Please watch for forms coming this year. We are anticipating a new form that is specific for DME in the next few months. We have also updated our interqual criteria and some other PA requirements. If any updates to criteria are more restrictive, they are announced in the Medicaid Information Bulletin. Also, before we end, just another quick reminder about an item that was discussed earlier in the training today. As of November 1st, 2017, facilities now require prior authorization for codes that have a PA requirement. Please review the article published in the October 2017 Medicaid Information Bulletin for more details, or refer to the earlier section of this training. I'd like to thank you all for allowing us to present this information to you. Today we have discussed the most important things that you should know to get you on your way to being a successful prior authorization submitter. To review other frequently asked questions, please click on the Frequently Asked Questions link from the Prior Authorization section of the website. And if you still have questions, please don't hesitate to call us at the number listed under the Contact Us link on the website. Thank you again, and please stay tuned for the Q&A portion for prior authorizations.
Hello, and welcome to the Utah Office of the Inspector General of Medicaid Services portion of provider training. My name is Gene Cottrell, and I'm the Utah Inspector General for Medicaid Services. I'm here to talk about the mission of the Office of the Inspector General, or OIG, and to provide some additional insight into what we do as an office for the Medicaid program. The OIG is an independent government agency legislatively established in 2011. We are tasked with providing oversight of all aspects of the Medicaid program in the state of Utah. The primary mission of the office is to protect taxpayer resources. The office performs both state and federal responsibilities. As such, the primary mission is broken down into two parts: oversight, which we accomplish through auditing, and program integrity, which we accomplish through investigations, inspections, and medical records reviews. The office is organized into 4 sections: Our audit section is comprised of 6 auditors that conduct financial or performance audits on the efficiencies and effectiveness of the Medicaid program. The Special Investigations Unit, or SIU, is comprised of 7 investigators specifically assigned to conduct investigations of referrals made to the office and to identify fraud, waste, and abuse within the Medicaid system. The SIU works in conjunction with our Program Integrity Unit, which has 4 additional individuals that work closely with Medicaid to ensure the integrity of the Medicaid program as a whole. The 4th section is a mission support section that provides administrative, data mining, and policy research support. We accomplish our tasks through 2 sources of authority. First, our oversight responsibility is assigned to us through Utah State Code 63A-13. Secondly, we perform program integrity responsibilities that are defined in the Code of Federal Regulations in 42 CFR 455 and 456. Those responsibilities are delegated to us from the Department of Health, who is designated as the single state agency responsible for the administration of the state's Medicaid program. The delegation of tasks associated with program integrity is accomplished through a Memorandum of Understanding. The Medicaid program is dynamic and very complex. It reaches into other state and federal governments, local counties, school districts, the medical and dental provider communities, and other entities. As the oversight agency, we are tasked to ensure that Medicaid funds are properly utilized in all aspects and areas of Medicaid. As our office conducts this mission, we have noted there are various causes of improper payments. These causes are defined by the state and federal government. This slide depicts what we have seen over the years and how our provider can start on one end of the scale and, if not properly checked, can find themselves on the other end. A large portion of the work the OIG does relates to common errors. When we notice these errors, we work with providers to solve them and help ensure that similar errors are not being made by similar peer groups within the Medicaid program. Waste, on the other hand, is when a provider may not be fully aware that billings and processes could be done in a more efficient manner. Waste frequently results in taxpayer dollars being spent inappropriately. Ultimately, OIG's mission is to protect taxpayer dollars, so anytime we identify areas where waste may be occurring, we work diligently to identify the problems and then make recommendations for stopping the waste from occurring. Abuse occurs when providers bend the rules in their favor. When this takes place, a provider may be right on the edge of intentionally committing fraud. We would encourage all providers that bending Medicaid rules in your favor is risky. If you have questions, please ask. Our job is to identify and report such behavior to the Medicaid program. When that occurs, it could result in a provider being unable to participate in the Medicaid program. Finally, fraud is intentional deception. These instances are taken very seriously and are reported immediately to the Medicaid Fraud Control Unit, which is responsible for investigating our referrals and prosecuting the cases if their investigation leads to criminal charges. Any self-identified instances of fraud and abuse should be reported immediately to the OIG. This slide defines fraud, waste, and abuse as they appear in Utah Code 63A-13-102. These are examples of fraud, waste, or abuse cases from other states. The OIG monitors activity in other states to help identify schemes that could take place in Utah. We then watch for indicators of that activity taking place in our Medicaid program. We are constantly on the lookout for these and other schemes. The OIG's primary focus is provider billing, but we are also very interested in recipient fraud. When an individual is intentionally deceitful to obtain Medicaid services, they may be committing recipient fraud. These are just some of the areas the OIG has seen that directly relate to Medicaid recipients. Any instance of potential recipient fraud should be reported to the OIG as soon as possible. The Department of Workforce Services investigates eligibility fraud, and the OIG passes on recipient referrals, especially cases where eligibility is in question, to the DWS Investigations Unit. Next, I'll discuss each of our sections a little more in detail. The audit section receives ideas to perform audits from many different sources, including legislation, Medicaid referrals, other states that have experienced fraud or difficulties, and even referrals from different providers themselves. An audit will determine the effectiveness of systems, positive or negative. They also help us identify areas for improvement or identify gaps in policy, from which the OIG makes recommendations for improvement to the Utah Department of Health. The audit process consists of first identifying systems for auditing, then understanding the process, developing an audit plan, conducting the audit, and finally developing and sharing the audit findings. Upon completion, each audit is distributed as needed and publicized on the OIG website. OIG audits are performed using generally accepted government auditing standards, more commonly referred to as GAGAS. The audit cycle is ongoing and starts with the funding of a program through various funding sources. The Department of Health, through the Division of Medicaid and Health Financing, then develops and manages the program through its own oversight of providers and contractors. In conducting oversight of the entire Medicaid program, the OIG identifies possible policy, contractual, and process weaknesses, and audits or evaluates these areas in order to make recommendations for improvement to the Department of Health. Finally, the OIG follows up to ensure changes are implemented and effective. The Utah Office of Inspector General has access to a variety of data, including Medicaid claims data. Medicaid claims data contains information regarding what healthcare services are being provided, as well as how much they cost. This information is vital for a variety of functions that the office performs. The office receives referrals from a variety of sources that must be reviewed or investigated. Data mining can be used to both confirm and deny allegations. While this may not be possible for all referrals, for many it can save time and resources by not having to request medical records for review. Data mining begins with cleanly extracting raw data from the Medicaid data warehouse. This takes knowledge about healthcare data coding systems as well as Medicaid claims data warehouse structure. There are millions and millions of lines of data each year added to the warehouse. Auditors and investigators need complete and accurate data to aid them in their reviews. Random samples are utilized so investigators can look at fewer claims and get a general understanding of provider behavior. Data analysis is used quite frequently to help identify patterns of waste, fraud, and abuse. Many different data modeling techniques are used to look at large data sets to determine if there are providers that are behaving differently than their peers. This allows proactive looks at provider behavior, which may include further investigations by investigators. The goal of the Utah Office of Inspector General's data team is to assist the team of investigators and auditors in their reviews. Data is not a standalone tool for fraud detection. Rather, it helps improve office investigation efficiency and can help identify fraud otherwise not apparent without a referral. OIG audits are performed using generally accepted government auditing standards, more commonly referred to as GAGAS. The audit cycle is ongoing and starts with the funding of a program through various funding sources. The Department of Health, through the Division of Medicaid and Health Financing, then develops and manages the program through its own oversight of providers and contractors. In conducting oversight of the entire Medicaid program, the OIG identifies possible policy, contractual, and process weaknesses, and audits or evaluates these areas in order to make recommendations for improvement to the Department of Health. Finally, the OIG follows up to ensure changes are implemented and effective. The Code of Federal Regulations set forth requirements for a state fraud detection and investigation program. It also requires the implementation of a statewide program to control utilization of Medicaid services. If these requirements are not met, a state may risk losing federal funding for their Medicaid program. The Special Investigations Unit employs multiple methods to validate the integrity of Medicaid claims. Reviews can range from very simple reviews to complex investigations. Sharing information and training providers corrects most billing inaccuracies. The OIG employs one full-time staff member that conducts reviews on Medicaid policies for our investigations and audits. This individual also conducts reviews on any changes in Medicaid policies before they are released to the general public. This slide lists some of the policy resource links that the office uses and that may be of interest to the provider community. These links direct you to the main page of each site, from which you can search for answers to questions you may have. The OIG is available to provide any additional training to providers and individuals as part of our oversight responsibility of the Medicaid program. If there are any questions for which a provider would like additional training, OIG will work with the Medicaid program to ensure training is provided. Please direct questions regarding training to the OIG training coordinator, whose contact information is included in an upcoming slide. If you suspect fraud, waste, or abuse is occurring at any level of the Medicaid program, we encourage you to report that activity to us. Referrals may be made through a number of means, including our fraud hotline and through our OIG website. As the Inspector General, I encourage all medical community members to help us actively seek out fraud, waste, and abuse to preserve taxpayer dollars. Program integrity is all of our responsibilities. OIG partners closely with these agencies. We work very closely with the Medicaid Fraud Control Unit, or MFUCU, when there are credible allegations of fraud. If fraud is suspected, we refer the case to MFUCU. MFUCU also receives allegations of criminal abuse, neglect, and financial exploitation when Medicaid recipients are involved. The Department of Workforce Services is designated as the agency that determines recipient eligibility. OIG investigates all instances of recipient fraud, waste, and abuse, but instances of eligibility fraud are ultimately investigated by the DWS Investigations Unit. Utah Adult Protective Services investigates complaints and suspected abuse and neglect of the state's vulnerable adult population, in particular, the elderly. Please follow the Utah Office of Inspector General of Medicaid Services at these online locations. We provide frequent updates and release results of audits on these sites. Thank you for participating in training today. We appreciate your time and help in accomplishing our mission of identifying fraud, waste, and abuse within the Medicaid system to ensure that taxpayer dollars are properly spent. If you have any additional questions, we encourage you to ask now or reach out to us at any time in the future. We are here to provide oversight, but we're also here to help. Thank you.